Hi guys, this is the lecture on chapter 10, pain, and this is going to coincide with the PowerPoint, and I added stars, right, because we're all stars. Anyway, I wanted to make this one a little more fun. So, chapter 10, patients in pain. Here are the things that you need to know about pain and patients. The outcomes are going to be make sure that you understand what are the definitions of pain, what are the myths and the barriers to effective pain management, especially in this day and age with the opioid crisis that we've got going on. You will hear a lot of mixed messages about pain management, so we'll talk about that. We're going to differentiate between addiction, physical dependence, and tolerance. And we're going to understand a little bit about what the pain response is, talk about nociceptive versus neuropathic pain. How do you assess pain? What do we use to treat pain? And, how we use other things as adjuvants or additional treatments for patients that are having pain. Okay? All right. So the first thing that we will talk about is, what is the definition of pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. International Association for the Study of Pain, 2017. Blah, blah, blah. And then I have what the actual definition is. Pain is whatever your patient says it is. Okay, don't forget it. Whatever your patient says it is. If you walk into a room to assess a patient and you ask them about their pain, they tell you it's a 10, but they're not screaming. Doesn't matter. It's a 10. Okay? That is the only time subjective information gets documented as something that's objective. Okay? So let's talk about acute pain versus chronic pain. Anything that is acute means it's usually a sudden onset, and it's usually a short-term thing. So if I'm in a car accident, let's just say, I'm going to have pain that is acute, but the idea is that over time, as I start to recover, that pain will improve. Okay, that's acute pain. Chronic pain, something that lasts typically for more than 3 months, and the signs and symptoms are persistent. They don't go away. Here's a good example. So you have your 78-year-old neighbor, Sarah, and Sarah has taken a fall, and she's got a fractured lumbar vertebrae. But because of her age and because of the fact that she's got hypertension and some cardiac issues, she's not a surgical candidate. So she's going to have chronic pain, and that needs to be managed because pain has some very, very bad effects on the body physiologically. And we're going to talk about what those effects are. We also have in here what the definition of suffering is. I just want to say one thing. Understand that when you're taking care of patients or residents in any type of a facility setting or even in a home care setting, I want you to just for a moment imagine that that is either you or somebody that you love. Okay? Remember, life is chaos. Be kind. Okay? These are people that have had lives and families. They're human beings. Be kind. All right, so uncontrolled pain, what can that do? So if you have a patient that is, say, a post-op patient, and they say something to you like, oh, no, I don't want to become a drug addict, so I don't want any pain medication. You have to make sure that they understand, and this is a statistical fact. It is in your textbook. I don't know how current that statistic is, but statistically speaking, for people that have actual issues with pain, so somebody that's a post-op patient, someone who's been in an accident, who's broken a bone, et cetera, less than 1% of the population that receives pain medication for pain becomes addicted. Less than 1%. That's minuscule, almost a negligible number. So the thing that you have to remember is when you see these commercials that say, oh, I was in an accident and then I got some pain pills and before the bottle was empty, I was an addict. The issue of addiction is multifaceted. Okay, it's got layers like an onion. You have to keep in mind that, people don't just wake up one morning and say, I have an idea. Let me hit up back Maryland and cop a bundle, right? And don't worry about how I know what that is. The point I'm making is that addiction's complicated. There are usually underlying either psychiatric or emotional or psychological issues that are the root cause of addiction. So truly, and we don't do a great job in this country of handling addiction. We throw people in jail, which is not a solution. What we need to do is get them the help that they need to figure out what triggered that addiction in the first place. Because the addiction is more the symptom than it actually is the disease. And that's important for you to remember as you go through your career. Okay, when we talk about pain, uncontrolled pain and the risks that are associated with it. If you are having severe or even moderate pain, you will see an increase in vital signs. Example, tachycardia, heart rate will increase. Hypertension, blood pressure will increase. I mean, the actual feeling of being in pain starts this whole chain of events that happens in people's bodies in response to that uncontrolled pain. And not only does it cause another set of problems, but it inhibits the healing process. Breakdown of tissue can happen at a greater extent when a person's experiencing uncontrolled pain because of these chemicals that get released, especially things called cytokines. And they actually will make the tissue break down more rather than the patient being able to heal, which is, absolutely the opposite of what we're looking to do when we're caring for these patients. Metabolic rate increases, in other words, that goes along with the hypertension, tachycardia, and tachypnea. Tachypnea is increased respiratory rate. Their immune system, when your immune system is stressed out and pain is a stressor, then your immune response isn't going to work. So you are a higher risk for infection. And then emotionally, who wants to be in pain all the time? No one does. And it also inhibits patients from doing things like ambulating and participating in self-care. And especially with post-op patients, we know how critically important it is to have a patient up ASAP to prevent things like, surgical-related pneumonia and surgical-related DVTs, right? So DVTs, which are blood clots in the legs, deep vein thrombosis, they are secondary to immobility. And pneumonia can be secondary to immobility. So if you're in pain, you're not going to want to get up out of bed. All these reasons why we need to manage patients' pain effectively. Now, you have to keep in mind that when it comes to pain, there are certain groups of people, whether we break them up by culture or we can even break them up by generation. So generationally speaking, from my generation, there's something called Stoicism. Stoicism, Stoicism. What that means is that we were taught, don't be a whiner, don't be a crybaby, shake it off, walk it off, right? So people my age and older are going to be less inclined to want to talk to you about their pain. So if you just ask this open-ended question like, are you having pain? Or, sorry, closed-ended question, are you having any pain? Most often, the patient's going to say, no. You have to ask more specific questions because there is no one that's my age or older that doesn't have some pain or discomfort even. So ask questions like, when you wake up in the morning, do you feel stiff or achy? If you're sitting for extended periods of time, ask specific questions because what you will find is then the patient will say things like, oh yeah, my lower back hurts all the time, but I'm used to it. So I don't even really count it as pain. It's still pain, right? Okay. You want to make sure that if there's a language barrier, and this is important, you have an interpreter. And the interpreter is not the janitor down the hall or even a family member if it can be avoided. Most facilities, actually I shouldn't even say that, all facilities now are required by Medicare to have some type of an interpreting service available. So whether it's a telephone call and say, all right, I have a patient that speaks Mandarin, I need someone to interpret for me. there are things that you can do to make sure that the patient understands your line of questioning, number one, and the patient's able to respond to you appropriately and give you the answers that you need. And every patient is different. Every patient is different. And so your approach is probably going to have to be tweaked a little bit depending on the patient that you're dealing with. So just remember, it could be you, okay? Always remember that. Take good care of these people. Okay. When we talk about who is responsible for managing pain, everybody that's involved with that person, with that patient, is responsible for managing pain. So in other words, the patient is the center of the healthcare team, okay? And the patient, when we think about nursing ethical principles and autonomy, the patient is an active participant in his or her own plan of care. So the patient is responsible as part of the healthcare team. You, the nurse, you're responsible. The physician, the nurse practitioner, even other modalities, in other words, the physical therapist, the occupational therapist, the speech therapist, the social worker. If the social worker is in and interviewing the patient, do you think the patient's going to be able to have a meaningful conversation with the social worker if they're experiencing pain? Probably not. So it's the social worker's responsibility to then get the nurse or the doctor and say, hey, I'm going to have to put this on hold for a little bit. Can you please take care of my patient's pain? And then I'll come back in a little while. So make sure you understand that. When we talk about opioid addiction, or really any addiction, there are three factors that the book talks about. I throw in the underlying cause, but that's a whole different chain of thought. But we'll talk about one thing at a time. Let's talk about tolerance. So tolerance means if I take the same medication over and over again at the same dosage, there will come a point in time where my body will become tolerant of that dosage and that med. It'll get used to it. And so let's say I take a sleep aid and I take the same dose of the same med every night and it's working just fine for about 6 months. But then after 6 months, I discover it's not really working right anymore. I'm not falling asleep or I'm not staying asleep. I've developed a tolerance. So now I've got to talk to my doctor or my nurse practitioner and do one of two things. Either I'm going to need a higher dose to achieve the same effect, or maybe I've capped out on the appropriate dose of that med and I need to go on a different medication. That's tolerance, okay? So you need to understand what that is. When we talk about physical dependence, there are drugs out there when they are taken consistently for a period of time that you can't just stop. Can't just, one day wake up and go, I'm done. I don't want any more of this. Because your body will go through withdrawal. That's a sign of physical dependence. I'll give you some examples. So opioids. Opioid withdrawal will make you feel like you're going to die. I have heard people pray for death while they're lying on the floor in the fetal position, having diarrhea and vomiting. But opioid addiction withdrawal won't kill you. You'll just feel like you're going to die or you'll wish to die. However, alcohol, benzodiazepines, which are things like alprazolam, Xanax, lorazepam, Ativan, diazepam, Valium. If you take those for more than 3 months consistently, and then you decide that you want to stop, you're going to be in trouble probably, because when it comes to benzos and alcohol, remember this, and this is critically important. Benzodiazepines and alcohol, when used consistently and stopped abruptly, can kill you. The withdrawal can kill you. Signs and symptoms of withdrawal from both benzos and alcohol are, initially it starts out with some mild tremors, shakiness, okay? If we don't do something for that patient, those mild tremors can progress to very big tremors. With alcohol withdrawal, those tremors are called delirium tremens. We know them as the DTs. And I've seen people shake so bad that they can't take a drink of water. Okay, they can't even hold anything because they're shaking so badly. If we don't do anything, those DTs or those severe tremors can progress to seizures, which can progress to coma, which can progress to death. So remember, benzos and alcohol, the withdrawal can kill you. Okay, it's important to remember. And the signs and symptoms are the tremors that progress to seizures, that progress to coma, that progress possibly to death. The treatment for both of those, benzodiazepine withdrawal and alcohol withdrawal, are benzodiazepines. Imagine that. So what we do is we will get the patient on a benzo and slowly titrate them down. In other words, we will wean them off, right? They need the benzo in their system because alcohol, contrary to popular belief, is a central nervous system depressant. When people think about alcohol, they're like, woo, shots, party's on, woo, going to the club. But what happens after that second or third shot? Start feeling a little funny and you start to have a slurred speech, right? So, in truth, alcohol is a central nervous system depressant, and so are benzodiazepines, which they're typically used for anxiety, chill pills we call them. And so because they're central nervous system depressants, when you're on something depressing your nervous system for a period of time, and then you just stop cold turkey, your central nervous system gets overexcitable. And that's why the tremors and the DTs and the seizures can happen. Okay, so that's important to understand. And then when we talk about addiction and psychological dependence, that's complicated, okay? Excuse me. That is the part that I talked about earlier when I said it's kind of multifaceted. It's like an onion. It has all these layers. So psychological dependence is the patient or the person saying, I cannot make it through the day if I don't have my meds. Okay. There are people out there that are opioid addicted that are just getting heroin to not get dope sick because they know what it feels like if they stop it and they don't have any in their system, and the vomiting and the diarrhea that they get, they feel like they're going to die, like I said before. So part of it is that, and then part of it is that psychological dependence. And then the other big part that we don't talk about is what caused that addiction in the first place. PTSD, or is there an issue of, major depressive disorder? And these are things that you'll learn, going through mental health. They're all important, right? And like I said earlier, we don't do a great job because throwing someone in jail because they have a problem with addiction, not the answer. That's my opinion, does not reflect the opinion of Prism Career Institute nor any of its affiliates. Okay, there's my disclaimer. All right, moving on. So I want to talk to you guys about the way that pain is transmitted. And this is going to be just short and sweet, okay? So don't worry about transduction. Don't even worry so much about transmission. The idea is, and the big one I want to talk about here is the perception of it, right? So give you an example. I am walking down the beach barefoot. I step on a shell, okay? The minute that I step on that shell, there's that impact and it cuts my foot. That is where the impact is. The transduction occurs there. My body goes, oh no, we have a problem. And when that happens, these chemicals will get released that transmit the signal to my brain so that my brain goes, ah, right? That's the perception. Then when my brain goes, ah, then I'm like, I realize I'm having pain. And, at that point, the perception of the pain is different for every person, okay? So anybody that's had a child, I've had 3 kids, and I had no meds, easy labors, no problems, no complications, the whole 9 yards. And then I talked to people that, they're only 3 or 4 centimeters dilated and it lasted for 10 hours and they were screaming in pain. Well, perception of pain is different for every person. Just remember that, okay? Don't worry about neurotransmitters right now. We're going to get into them a little bit more later, but just to let you know, when we talk about neurotransmitters are chemicals that the body makes that help transmit signals through the nervous system. Endorphins, they're the happy chemicals, right? They're happy chemicals. They're the ones like if you fall in love, you're like, the world is lovely and everything's great. It's because your body's pumping out all kinds of endorphins. When we talk about studies, and I do love to read studies, multiple studies have been done on how you can actually stimulate your own body to produce more endorphins. So, for example, I walk into work all the time. I have my music on. You guys have probably seen me. Why do I do that? I do that because music makes me happy. Happiness is a state of mind. It's not about how much money you have, because if money were the answer, there wouldn't be any rich people committing suicide, and they do it all the time, right? It's not about money. It's not about fame. It's not about love. It's about a state of mind. Choose to be happy. And so when I play my music and I'm singing along to Salt and Pepper and whatever old school jams I'm listening to, my body, my brain is making my body release these endorphins, and I stay happier, right? So it's kind of the equivalent almost of people taking an antidepressant, kind of elicits the same effect in the body. Isn't that a fun fact? Okay, all right. I want to talk about the difference between nociceptive pain and neuropathic pain real quickly, and this will be short and sweet too. Neuropathic pain, that's just self-explanatory. When you see neuro in a word, N-E-U-R-O, neurological. Neuropathic pain is nerve pain, and it's related to nerve damage, okay? Specifically nerve pain. When we talk about nociceptive pain is more about tissue damage, a cut or a scrape or even something internal. So just know these two words. With nociceptive pain, it's either somatic or it's visceral, okay? Somatic means superficial. So, I get a little cut on my hand. Ooh, it hurts. Right. Visceral pain is deep, deep, deep pain. In other words, a kidney stone. And when we get to GU, you'll learn about this. But kidney stones are probably up there in the top 5 most painful conditions that a patient can have. It's a deep pain, deep, deep. So visceral pain comes from deep within, like organ damage, right? Or kidney stones, those kinds of things. Somatic pain is a superficial. It's a cut, a scrape, a laceration, those kinds of things. And they both fall under nociceptive. Neuropathic pain is all by itself. It's nerve pain. The next slide talks about referred pain. Referred pain just means that I have damage to something, say cardiac. Say I'm having a heart attack, a myocardial infarction, which typically is painful. You would think that the area would be chest pain. Not always. Sometimes the patient will experience what we call referred pain, which is pain at a site other than the site that's being compromised. So, patients having heart attacks can have arm pain. And fun fact, it doesn't have to be your left arm. It can be right or left arm, okay? They can have lower back pain. They can have neck pain. And for females, another fun fact, cardiac pain can present as pain, GI pain, like indigestion that's persistent over time. All of those things are referred pain. So you take a look at the chart that's in the PowerPoint, and it'll show you different areas that are common for referred pain. Okay. When we talk about pain treatment, there are drugs that we can use, analgesics. Analgesics are medications to relieve pain. And they can be opioid analgesics. They can be non-opioid analgesics. And then there's a category that's adjuvant, and we'll talk about that. Opioid analgesics are meds like morphine, codeine, Demerol, which is meperidine, Dilaudid, OxyContin, oxycodone, hydromorphone, right? The Percocet, Vicodin, Lortab. Those are all opioid analgesics. And can't forget fentanyl. Fentanyl's a big one. Okay. So those, do have addictive qualities to them, but when they're used the right way, typically don't produce an addict just, out of the blue. Non-opioid analgesics, and we have subcategories here too. This is important. So for non-opioid analgesics, the big one that everybody knows about, acetaminophen, good old Tylenol. Acetaminophen is a non-opioid, over-the-counter, analgesic, and it's an antipyretic too, so it'll reduce fever, right? The thing that you need to know about acetaminophen that's critically important is it is hepatotoxic. In other words, it can cause severe liver damage. Never give acetaminophen to someone who's got liver problems or someone who's drinks alcohol on a regular basis, because you can actually shut down their liver. Other non-opioid analgesics, NSAIDs, non-steroidal anti-inflammatory drugs. And under that umbrella, we've got ibuprofen. Ibuprofen, also known as Motrin or Advil, right? We also have naproxen or naproxen sodium. Well, that's Aleve, non-steroidal anti-inflammatory. Then we have meloxicam, also known as Mobic, and then we have celecoxib, also known as Celebrex. Those are all non-steroidal anti-inflammatory drugs. They decrease inflammation, and by decreasing inflammation, they typically will decrease pain. They carry with them risk of GI bleed, all of them. Non-steroidals cause a risk of GI bleed, peptic ulcers, gastric ulcers. The other thing to keep in mind, especially only with Celebrex, which is celecoxib. If the patient's allergic to sulfa, they cannot have celecoxib. I'll say it again. If your patient is allergic to sulfa, they cannot have celecoxib. Also, if your patient has any cardiac history, they have a history of blood clots, DVTs, thrombophlebitis, history of MI, heart failure, hypertension, they cannot have celecoxib. Okay, so make sure you know that. Okay, opioid antagonists. An antagonist is anything that blocks the effect of the drug. Narcan, naloxone. That is the queen mother, if you will, of the opioid antagonists. So if somebody is overdosing, say on a heroin or an opioid, or even in post-op, we keep naloxone on hand. Why? Because sometimes after a patient has surgery, they don't wake up on their own from the anesthesia. And so we have to give them something to block the effect of the opioids and wake them up. Okay. The next slide talks about placebos. Here's all I'm going to say. Placebo, the word placebo means a fake, a phony. So in other words, you think you're taking medicine and it's just a sugar pill. It's not a real pill. That's never appropriate. Let me say that again. Never appropriate to tell someone they're taking something and you're lying to them. That defeats veracity, right? Nursing principle of veracity. Okay. All right, so we're going to talk about now roots of analgesia. You can read that for yourself, oral, rectal, inhalation, IV. I do want to quickly talk about PCA pump, patient-controlled analgesia. With a PCA pump, there is usually an opioid in the pump, and it's going into an IV in the patient, and the patient has a button that controls additional PRN doses. Let me explain. Let's say the patient's a post-op patient and we have them on a PCA pump with morphine. We will have a basal rate set, say 1 milligram per hour. So that PCA pump is constantly and consistently delivering through the IV 1 milligram of morphine every hour, slowly, right? Basal, the word basal means slow and steady, okay? But then in addition to that, we also have it loaded to give boluses. A bolus is a one-time, boom, shot of something. So a bolus is a PRN dose. So the 1 milligram per hour is the basal, what they're getting constantly. But then we've got it programmed that they are permitted to get, say, 1/4 of a milligram of morphine every 15 minutes. Well, they could push that button all day long. It doesn't matter. They're only going to get that extra 1/4 milligram dosage every 15 minutes to prevent an overdose, okay? And yes, the patient should be the one pushing the button. It's important to understand, though, that when we dose patients with opioids, we don't just go, spin the wheel, give them this much. It's based on, are they opioid naive? In other words, have they never had an opioid before? We're not ever going to give a patient a dose of medication that is higher than something that their body can tolerate. Okay, it's done very carefully and judiciously. Alternative therapies that are non-pharmacological. Things like guided imagery. In other words, close your eyes and picture yourself in a place that makes you happy. They work as adjunct. In other words, they're not a replacement of, but they are definitely in addition to, pain medications that are used. I want to talk about pain assessment real quickly. When we talk about pain assessment scales, just understand you have to know the scales and you have to understand how to assess your patient. What do I mean? Here you go. With a patient that's having pain, the first question is, where is the pain? And if you want to save yourself a lot of time, you ask them, have you ever had this pain before? Because if the answer is yes, you just save yourself a lot of time, because then you can say, well, oh, you did have it before? Tell me what happened. If the answer is no, well, then you have to ask them, where is it? How is it? How does it feel? That's qualifying the pain. Qualifying pain means describe it. Is it burning, throbbing, aching, stabbing? Aggravating and alleviating factors. What makes it better? What makes it worse? The timing. Does it come and go, or is it just there? How severe is the pain? For people that are awake, alert, and oriented, you use the numeric scale. 0 is no pain, 10 is excruciating. Put a number to it. So there you're quantifying the pain. Quantifying, quantity, putting a number on it, right? How bad is the pain? And I put the scales up there so that this way you can see them. You've got the numeric scale. You've got what's called the Wong-Baker Faces scale. That's used primarily for children, sometimes for adults that are cognitively impaired, that have, the brain capacity of a child. And then you've got the Flack scale. And I added this one in because you need to know the Flack scale. And the Flack scale is usually used for infants. What it does is it's based on the observation of the healthcare provider. You're looking at the baby, the infant's face, you're looking at their legs, you're looking at their activity, you're looking at their cry. Are they crying? You're looking at their consolability. So consolability means if I rock the baby or hold the baby, will it stop crying, or does it just keep on crying? So make sure you know the Flack scale. Make sure patients are educated about all the possible side effects of whatever drugs we're using. And that is the end of my pain lecture. I hope you enjoyed it. And I'm going to get back to what I was doing. Peace out.